Okay. Good evening, everyone. Welcome and thank you for joining us tonight in this very unique and new activity. Just in the beginning, I would like to put a reminder that this is the first series of the first episode of this series. Today is the 17th. And we will speak about the psoriatic arthritis. And in 14th of January, I will have the honor to join Professor Ghaffar to speak about gout. And then on the 28th of January, we have also two eminent professors speaking about the differential diagnosis and the early diagnosis of rheumatoid arthritis versus osteoarthritis. We have very, very few and selected pioneers internationally gathered for this chain. I would like first to, so remember the dates, please copy the dates. And I would like to thank, to start with Amgen company for holding the activity and sponsoring this nonprofit scientific work. Amgen is a very big company and they have an immunology research lab and biologics and biosimilars and so forth. And I thank them for holding such a scientific activity. Also, thank you to Iris company holding the platform and the logistics. I want to just say a few things about our society. Our society today celebrated 10 years of its age. I know it might not be so long, but it's a very, very strong, scientifically strong society represented in all the universities in Egypt, plus the Armed Forces Hospital. And it has a very unique character in having three satellite schools affiliated to the society. The ultrasound school, which I am honored by being the scientific director of it, is one of them. And we also have an immunology school and metabolic bone disease school. This society is headed also now by the president of the society, Professor Mohammed Salah Abdelbaki. He is, of course, one of the important co-founders and a member of the assembly. And he is the ex-president of the rheumatology department in a big university in the whole Middle East and internationally, Ain Shams University. And I remember Professor Salah, he is actually, when I was an intern and fresh graduate assisting a professor, we used to see him pushing the immunology unit and the lab, in the immunology lab. I remember doing all the immunology tests, and he's pushing this rheumatology and immunology specialty. He also established postgraduate degrees and holding the certificates from the university for this specialty. And what might not be known by the attendees, that he also discussed me and I had to defend my thesis in his presence, a master thesis. This was long years ago. So I'm really grateful for him to allow me this chance today. And I have to tell you, everyone, that I am very relieved. You don't know how much that I am not presenting today and only coordinating and listening to my teachers. I will also share this screen about today, because also Dr. Carlos Acebes from Spain will join us tonight. For those who don't know, Dr. Carlos is my teacher, my mentor, my great professor, my friend who teach me ultrasound. And by the way, Carlos, if you don't know, in my workshops, I always explain that I went to Spain and to a specific professor because he was very organized in one EULAR course I attended. He was very specific and very illustrative. So I like the idea. I talked to him and he managed to make me a very excellent program in Spain in 2008. I'm very, very grateful for this. And he is the chairman of the rheumatology unit in Hospital General Villalba. Villalba is in Madrid, and he also worked as a consultant in Scotland and in the UK in many positions, many places. When I was there in Spain in 2008, he used to work in a hospital called Fundación Jiménez Díaz, and I remember very well, and I remember the machine. It was very, very excellent machine. Of course, Carlos Acebes is also EULAR faculty in the ultrasound courses. Everyone attending today, I encourage you to send your questions through the question and answer button in the bottom of the screen. I thank all the professors contributing to the whole series, but I specifically tonight thank Dr. Mohammed Salah and Dr. Carlos Acebes for joining us, and I will be receiving your questions, and I will leave the platform to Dr. Salah to start today. It's a very unique session, giving all the updates and the tricks in the clinical point of view, and then the ultrasound view of the same topic. So I hope everyone will find it interesting, and let's listen to our professors. Thank you very much. Dr. Salah, unmute and please go ahead.
Bismillahirrahmanirrahim. I welcome all of the attendees first. I want all of you to welcome Professor Carlos Acebes, our guest today, eminent figure in rheumatology and ultrasonography of musculoskeletal system from Spain. Welcome him. We're happy to be with us today. I want to thank Dr. Adham Abul Futuh for coordinating this rheumatology musculoskeletal ultrasound induction course that to be the first time to do this combined clinical and ultrasound work for the same subject. I think it's very beneficial and a very good idea. I thank him. Dr. Adham Abul Futuh is international muscular ultrasound trainer, EULAR certified, and he is scientific director of our School of Ultrasound of the Egyptian Society of Rheumatology and Clinical Immunology. Lastly, I wanted to thank Amgen Pharmaceutical Company for their share in this non-promotional scientific activity. I welcome all of you. Let us begin. Our subject is pills and diagnosis and management of psoriatic arthritis. These are my disclosure. These are evidence-based missing key references. Our objectives today is to identify the different presenting patterns and features of psoriasis and psoriatic arthritis and comorbidities accompanying them. Review of classification criteria and diagnostic approach. Review of current and emerging treatment options for patients with psoriatic arthritis. Let us have a look on the new concept of spondyloarthritis. This is a new concept. Actually, you know this famous picture, but the change here is spondyloarthritis now divided into axial spondyloarthritis. Instead of presence of ankylosing spondylitis in the middle as a big circle like before, no. Today we have axial SPA divided into non-radiographic axial SPA, whereas there is no evidence of radiographic change in the conventional radiology, and radiographic axial SPA with evidence of radiographic change on conventional radiology according to modified New York criteria. You can call this ankylosing spondylitis. And then peripheral spondyloarthritis constitutes reactive arthritis, psoriatic arthritis, and arthritis associated with inflammatory bowel disease. If you have no criteria to diagnose any one of these, it will be undifferentiated peripheral spondyloarthritis. This is the new concept for spondyloarthritis. Let us see what about psoriatic arthritis. Actually, psoriatic arthritis is a chronic inflammatory arthritis associated with psoriasis. About 25% of patients with psoriasis will eventually develop psoriatic arthritis. The skin usually precedes joint affection in about 85% of patients, often over 10 years. The joint involvement may be peripheral or less likely to be axial in not more than 20% of patients. It will include extra-articular features like enthesitis, dactylitis, skin and nail changes. Serology is supposed to have seronegative arthritis. Psoriatic arthritis is a form of seronegative arthritis, but you may find positive rheumatoid factor in about 10 to 15% of cases, and even highly specific NCCP, you will find it in about 10% of cases of psoriatic arthritis. As I told you, comorbidities may be the form of metabolic syndrome and the cardiovascular disease. We'll mention this later on. The prevalence of psoriatic arthritis. Psoriatic arthritis is highly prevalent in patients with psoriasis. If you have a look at the prevalence in Egypt, this is Egypt here. If you have a look here, it will be from 20 to 25% of patients with psoriasis will develop psoriatic arthritis. This is the prevalence in our country, Egypt here, as you see here. As you see, there is wide variation from less than 5% to more than 30%. Wide variation according to the geographic area, genetic background, and the series selected and the criteria of selection of this series. For this reason, there is wide variation in the prevalence from one place to another place. Psoriatic arthritis has 6 domains, 6 famous domains: skin psoriasis, nail psoriasis, peripheral arthritis, axial spondyloarthritis, enthesitis, and dactylitis. These are the 6 domains of psoriatic arthritis. Let us have a look on the skin domain. There are 5 subtypes of psoriatic rash. This is the commonest type, which we all know, the scaly red rash of plaque psoriasis. This occurs from 85 to 90%. This is the most of cases will be plaque psoriasis. But there are less common types of psoriasis, usually diagnosed by dermatologists, difficult to be diagnosed by non-dermatologists, like Tate psoriasis, inverse psoriasis, pustular psoriasis, and erythrodermic psoriasis. Let us have a look on the subtypes of psoriatic arthritis. We have also 5 types of subtypes of psoriatic arthritis: distal, oligoarticular, polyarticular, axial, and arthritis mutilans. This is very rare, actually, less than 5%. We will see that the most important types of psoriatic arthritis are oligoarticular, asymmetric oligoarticular arthritis. This is the most common cause of psoriatic arthritis, or pattern of psoriatic arthritis. About 70% of patients with psoriatic arthritis will present with asymmetric oligoarticular arthritis. It can affect any joint, including distal interphalangeal joints of both hands. Less common, symmetric polyarthritis. About 20% of patients with psoriatic arthritis will present with symmetric polyarthritis, similar to rheumatoid. This may be sometimes difficult to differentiate from rheumatoid. Usually affects multiple symmetric pairs of joints like you see here. These are the 2 most important types of psoriatic arthritis. Axial affection is similar to axial SPA. Spine pain may be reported in up to 50% of patients with psoriatic arthritis, but predominant axial forms are infrequent. The range is quite variable from area to area, maybe from 5% to 20% or more of cases will have an axial affection. Enthesitis is a very important hallmark in psoriatic arthritis. Enthesitis represents inflammation of entheses as sites where tendon and the ligaments and the capsule insert into the bone. Enthesitis is a hallmark pathologic lesion in spondyloarthritis and is common. It's present in from 35 to 50% of cases of psoriatic arthritis. Enthesitis differentiate psoriatic arthritis and spondyloarthritis in general, because the enthesial disease with or without secondary synovial membrane may occur. To be differentiated from rheumatoid arthritis, for example, where the primary synovial membrane is the main pathology. Enthesitis may occur sometimes subclinically, preceding the appearance of real psoriatic arthritis. And the ultrasound will be very useful here in detection of subclinical enthesitis in these patients. These are the common sites of enthesitis, as you see here. Plantar fascia, this is a common plantar fascia and Achilles tendonitis, patella and iliac crest, both iliac crest and epicondyles, supraspinatus and the lateral condyle of femurs. This is a picture here of tendo-Achilles tendonitis. This is a very important feature of psoriatic arthritis, and a very important feature can be detected subclinically by ultrasound, as Dr. Carlos will talk to you. Dactylitis, another important feature of psoriatic arthritis. Dactylitis represents inflammation of joints, flexor tendon sheaths, adjacent soft tissues of the whole digit. May involve one or more digits. Usually in the foot, third and fourth toe commonly affected. Third and fourth toe may affect the fingers, like you see here. Dactylitis represents a common clinical feature of psoriatic arthritis, being observed from 15 up to 50% of cases of psoriatic arthritis. Again, what are comorbidities? Psoriatic arthritis is a systemic disease with marked burden. It may be accompanied by frequent comorbidities. We have cardiovascular comorbidities, accelerated atherosclerosis, heart attacks, stroke, and increased cardiovascular mortality. Metabolic syndrome, obesity, insulin resistance, cholesterol abnormalities, and hypertension, diabetes, mood disorders in the form of anxiety, depression, and suicidal tendency, Crohn's disease, inflammatory bowel disease, lastly, rarely, malignancy like T-cell lymphoma. These are comorbidities which will be encountered in cases of psoriatic arthritis. Let us progress to diagnosis. How can we diagnose psoriatic arthritis? Actually, there is no single test to diagnose psoriatic arthritis. It is a challenging disease. I have no markers, no serological markers. So the clinical evaluation, mainly aided by some laboratory and imaging techniques, are very helpful for diagnosis. Let us have a look on the traditional conventional picture of psoriatic arthritis in the conventional X-ray. It has a characteristic radiographic features. If you have a look here, you will find eccentric marginal erosion, like here, causing this pencil, and at the same time there is erosion, and at the same time new bone formation, bony proliferation, but fluffy like this, fluffy periostites. This is the classical picture of pencil in cup appearance, denoting eccentric erosion and new bone formation, fluffy periostitis, as you see here, like this. As regards axial affection, how to differentiate? Is it ankylosing or axial affection of psoriatic arthritis? You may find here unilateral. In case of psoriatic arthritis axial affection, we will find unilateral sacroiliitis, and syndesmophytes are bulky and paramarginal, not marginal. This may differentiate axial affection in the psoriatic arthritis from usual ankylosing spondylitis. This is the different modalities for imaging in psoriatic arthritis. As I mentioned, it's just conventional radiology to detect the structural damage and monitoring. But as you see here, to see this picture in a patient with psoriatic arthritis, it will be very late, actually. This is not helpful for early diagnosis. As the same like in rheumatoid arthritis, I should not wait to see erosions in the X-ray to diagnose rheumatoid arthritis. I should not wait to see bamboo spine ankylosing spondylitis to diagnose ankylosing spondylitis. Now, early diagnosis is very important to interfere, to treat, to target, to avoid permanent disability. So this is the role of ultrasound now. Ultrasound is very important tool now for early diagnosis and for monitoring the disease. This will be the lecture of Professor Dr. Carlos Acides after me. And MRI may be used, but of course it will be useful, but as you know, it's expensive, not available all the time, difficult, is that time consumed. So the ultrasound is a magic solution for help in early diagnosis of psoriatic arthritis. These are CASPAR classification criteria. CASPAR means classification of psoriatic arthritis. CASPAR criteria, this is an abbreviation for classification of psoriatic arthritis, as you see here. To meet CASPAR criteria, a patient must have inflammatory articular disease, either joint or spine or enthesitis affection, and to have a score of 3 or more from these categories. The first category, evidence of psoriasis. Current psoriasis, 2 points. History, personal history of psoriasis, 1 point. Family history of psoriasis, 1 point. Psoriatic nail change, the second category. Pitting onycholysis or hyperkeratosis, 1 point. Negative test for rheumatoid, 1 point. Dactylitis, either current swelling or history of dactylitis documented by rheumatologists, each will take 1 point. And lastly, radiographic evidence of juxta-articular new bone formation, ill-defined ossification near joint margin, which we have just seen now, 1 point. If you have 3 or more from this, added to presence of inflammatory arthropathy, joint or spine or enthesitis affection, you can classify this patient as having psoriatic arthritis. These criteria have high specificity, more than 98% specificity, and also very good sensitivity, more than 91 sensitivity. So how can I diagnose my patient presenting to me in the clinic with arthritis? Is my patient with polyarthritis have psoriatic arthritis? This is a question. If this patient presenting to me, this is the second one here, with affection, as you see here, asymmetrical polyarthritis, but he have unilateral sacroiliitis, he have dactylitis, maybe in the fingers or in the toes. If I have history from this patient, if I found psoriasis or history of psoriasis or family history of psoriasis, if I find nail changes in this patient, all of this, I can diagnose this patient as psoriatic arthritis confidently. Ultrasound may help in early detection of enthesitis, also may be of great help. This is to differentiate our patient from patient with rheumatoid arthritis like this, with bilateral symmetrical synovitis affecting most of joints. There is no axial affection. There is no dactylitis. There is no enthesitis. Maybe a strongly positive rheumatoid factor or anti-CCB positive with high elevation of EGYSIR and CRP. This is osteoarthritis. Of course, osteoarthritis is a non-inflammatory arthropathy. No evidence of inflammation, either clinical or by laboratory, and you will find asymmetrical affection of weight-bearing joints quite different. The affection of the distal interphalangeal joint may cause some confusion, but if you find other criteria, as I told you, of psoriatic arthritis, it will be helpful. So the clinical, as you see, based on clinical judgment and applications of the available clinical data to complete the criteria needed to diagnose or to classify psoriatic arthritis. Why you are worried about the early diagnosis of psoriatic arthritis? Actually, if we have inflammation here, inflammatory back pain or inflammatory peripheral arthropathy, like psoriatic arthritis, it will cause a form of disability, more pain and more stiffness, and these things will cause disability. But disability is reversible. once I control this inflammation with proper treatment. But if this inflammation prolonged without intervention, with delayed diagnosis, will cause irreversible damage here. This is the picture which you have seen. This is too late to diagnose psoriatic arthritis based on this picture. It will be irreversible damage, and accordingly, the disability caused by this damage will be irreversible. The concept is very important of early diagnosis, early treatment, treat to target, and control inflammation to control disability, to prevent irreversible damage, to prevent the irreversible disability. So if you have a delay as short as 6 months in diagnosis of psoriatic arthritis, it is associated, as you see here, with worse outcomes, as you see, development of peripheral joint erosions and worsening of health questionnaire. If more delay, more than 1 year, development of arthritis multilines and lower chances for achieving drug-free remission, worse quality of life and functional disability, and it will be irreversible in this condition. This is the importance of diagnosis and early diagnosis. Let us shift to what is about treatment of psoriatic arthritis. As in rheumatoid arthritis, we should have a target to treat in SPA or in psoriatic arthritis. Treat to target concept is also supported by some evidence. If we have an active SPA or psoriatic arthritis, our main target is to achieve remission. The alternative target to achieve low disease activity. So adapt your therapy according to the disease activity. Use clinical measurements, validated measures. In case of psoriatic arthritis, we have DAPSA or MEDA. Then when I attain my target of remission or low disease activity, I adapt my therapy to sustain this remission or to sustain this low disease activity throughout the course of the disease, taking on consideration extra-articular manifestations and comorbidities to decide about the proper treatment. This is treat to target concept. What is the definition of remission or low disease activity in psoriatic arthritis? Actually, it may be more difficult than in case of rheumatoid arthritis. We have many measures, but the two measures mentioned is the treat to target recommendations by the EULAR issued in 2017. We have VLDA, very low disease activity, and the MEDA, minimal disease activity. We have 7 points to be fulfilled: tender joint count less than 1, swollen joint count less than 1, skin psoriasis, psoriasis area severity index less than 1, enthesitis less than 1, pain score less than 15, patient global assessment less than 20, HAQ score less than half. If you have the 7 points, then you have very low disease activity, 7/7. If you have only 5/7, you have minimum disease activity. What about DAPSA? DAPSA means the disease activity index for psoriatic arthritis. We have 5 points: number of tender joint counts, swollen joint counts, pain score, patient global assessment score, and lastly CRP as an objective measure, CRP. If you have DAPSA less than 4, you are your patient in remission. If from 5 to 14, it is low disease activity. So by using of these validated measures, we can reach our target and keep target of remission or low disease activity throughout the course of the disease. Let us have a look on the treatment used to achieve our goal of remission or low disease activity. This is a timeline for psoriatic arthritis recommendations and drugs. From early 1960, you know, that disease-modifying antibiotic drugs like methotrexate, salazopyrin, and leflunomide. Then leflunomide from the 2000s with biologics. Then from 2000s, we have TNF inhibitors group: etanercept, infliximab, golimumab, certolizumab, and adalimumab. Then we have Secukinomab, 2013, Secukinomab, interleukin 12/23 inhibitor. Then Secukinomab in 2015, interleukin-17 inhibitor. Apremilast is not available in Egypt, apremilast. And then tofacitinib in 2018, tofacitinib approved as a treatment for psoriatic arthritis at that year. And we have biosimilars for different TNF, infliximab, and etanercept. And in Egypt, we have Adalimumab biosimilar now, Amgevita, available now in Egypt. And then the last one approved is Guselkumab, interleukin-23 inhibitor, approved just in July 2020. And these are the potential waiting for further trials and to be approved later on. These are waiting in the pipelines. Okay, let us have a look on the list of the drugs used in treatment of psoriatic arthritis. We have non-pharmacological therapies like physiotherapy and occupational therapy and so on, smoking cessation, symptomatic treatments like NSAIDs and local injection of steroids. Then, as I told you, disease-modifying drugs, methotrexate, sulfasalazine, cyclosporin, leflunomide, apremilast, TNF inhibitors, etanercept, infliximab, adalimumab, golimumab, and certolizumab, interleukin-12, 23 inhibitor, ustekinumab, and the last one approved, interleukin-23 inhibitor, Guselkumab, Tremfya. It's called the Tremfya. It will not available yet in Egypt, but coming soon. Interleukin-17 inhibitor, Secukinomab, CTLA4, abatacept, and lastly, JAK inhibitor, tofacitinib. How can we use these different medications according to their indications? As you see here, the different indications for different biologics approved. TNF inhibitors need approved in all aspects of SPA, especially monoclonal antibodies, not receptors. Monoclonal antibodies are approved in all aspects of SPA, including psoriatic arthritis, axial SPA, psoriasis, Crohn's disease, ulcerative colitis, and uveitis. T-cell co-stimulator, abatacept, approved in psoriatic arthritis and added to rheumatoid, of course. Interleukin-12, 23 approved for psoriatic arthritis, psoriasis, and Crohn's disease, Secukinomab. Interleukin-23 recently approved for psoriatic arthritis, and it was approved before for psoriasis. Interleukin-17, Secukinomab, approved for psoriatic arthritis, axial SPA, either radiographic or non-radiographic, psoriasis, but contraindicated if the patient has active Crohn's disease, contraindicated. JAK, tofacitinib, indicated for psoriatic arthritis and ulcerative colitis, and as you know, of course, rheumatoid arthritis. And this one, the last one, apremilast, approved for psoriatic arthritis and psoriasis. It's not available in Egypt, this one. Apremilast not available in Egypt. Phosphodiesterase 4 inhibitor. Let us have a look on the newest drug for psoriatic arthritis, just approved in last July 2020, Guselkumab, Tremfya. This is interleukin 23 inhibitor. It's given 100 milligrams subcutaneously at week 0, and then week 4, and then every 8 weeks. This is a trial published, which after this, the drug was approved for treatment of psoriatic arthritis. Let us have a look on important head-to-head trial to compare Secukinomab and Adalimumab, the most commonly used drugs mostly in Egypt here for psoriatic arthritis. This is EXCEED trial to head-to-head to compare Secukinomab versus Adalimumab. More than 850 patients with active psoriatic arthritis with inadequate response to the MARS. Double-blind, double-blind direct comparator trial use Secukinomab 300 milligrams with loading dose, and Adalimumab 400 milligrams every other week. The primary outcome was ACR20 at 52 weeks after 1 year. Actually, the response, ECR response and ECR 50 response and the HAC were very near. There was no significant difference. The only difference may be, although not significant, no significant difference between both drugs. So Secukinomab is efficacious as Adalimumab. Both are similar as efficacy. There is some difference as regards discontinuation of the rate at 52 weeks after 1 year. Secukinomab discontinued in nearly 14% of cases, while Adalimumab discontinued in 23% of cases. Slightly higher Adalimumab discontinuation. The other thing here is the difference in the PASI 90, psoriatic area severity index 90 response. It was higher in Secukinomab group, 65% against 43% for Adalimumab. Now let us shift to treatment guidelines. How to use these drugs? The guidelines, we have GRAPPA guidelines, group of research of assessment of psoriasis and psoriatic arthritis guidelines, published in 2016. They base their guidelines on the different 6 domains of the psoriatic arthritis, which I have just mentioned to you: peripheral arthritis, axial disease, enthesitis, dactylitis, skin, and the nails. This is number 1. Number 2, they have 2 ways of therapeutic route, either a standard route, which is a straight line like this, and expedited therapeutic route, which is dot line like this. This means exceptional. You may go to this route whenever you need, if you think this condition is severe or has poor prognostic factors. Here for peripheral arthritis, for example, we use the MARD first, and then after failure, use biologics, different biologics. You can choose any biologic, or if it is severe or you have poor prognostic, you can use the expedited line from the start, and then you can shift between different biologics. For axial disease and enthesitis, a trial of non-steroidal anti-inflammatory drugs first. After failure, maybe 4 weeks, maximum 12 weeks, you try then biologics. There's no place here for conventional synthetic DMARD. Try biologics, and then if you fail, you shift between different biologics. The biologics approved for either for axial or for enthesitis or for joints, according to the approval, I mean. In cases of dactylitis, you use NSAIDs, then the MARS, then biologics, and you can shift between different biologics. And the skin is the same, topical, then the MARS, then biologics, and you can shift between different biologics. And lastly, nails the same way. This is GRAPPA guidelines for management of psoriatic arthritis. Let us have a look on the most recent recommendations for EULAR recommendations for treatment of psoriatic arthritis, issued on 2019 and published recently in this year, 2020. This is phase 1. If you have a clinical diagnosis of active psoriatic arthritis, if you have polyarthritis, more than 4 swollen joints, with or without dactylitis, or if you have oligoarthritis with poor prognostic factors, severe form with dactylitis or something like this, we can go directly to use conventional synthetic DMARDs, methotrexate, leflunomide, sulfasalazine. If it is oligoarthritis with no poor prognostic, you will give a trial of non-steroidal and local injection of steroid. If within 4 weeks you have achieved the target, okay, continue. If not, you will join this line. You will check after using this conventional synthetic DMARD after 3 months. If you have significant improvement, 50% at least, or you reach the target of remission or low disease activity after 6 months, yes, you will continue. If no, you will shift to phase 3. Here, in case of enthesitis or predominant axial disease, trial of NSAIDs from 4 to 12 weeks. If you did not achieve your goal, if yes, continue. If no, you will shift immediately to the next phase of biologics. This is phase 3 of biologics. This is the failure after failure of polyarthritis or enthesitis. You can use biologic DMARD TNF, or any of the biologics can be used for polyarthritis or enthesitis. TNF inhibitors, interleukin 12, 23 inhibitors, interleukin 17. Interleukin 23 was not yet approved to be put here in these recommendations. After this, you may use, after failure of this, or if there is any contraindication for them, you can use JAK inhibitor. And the lastly, you may use apremilast, the last one. In case of axial affection, as we told in the last phase, if you have failure to initiate, you'll shift immediately to biologic DMARDs. No way for conventional synthetic DMARD. You start the biologic either TNF inhibitors or interleukin 17. Interleukin 12, 23 not approved for axial disease. They are telling that usual practice is to use TNF inhibitor. You can use, of course, both of them, but they are telling because more experience to start with TNF inhibitor. Again, the same way. You check after 3 months if significant improvement, 50% at least, or you achieve target of remission of low disease activity after 6 months. Yes, you will continue. No, you will shift to phase 4. Phase 4 is shifted between different biologics. Phase 4 in cases of arthritis and enthesitis, you will shift between the approved biologics, either TNF inhibitors, interleukin 12, 23, or interleukin 17. Or after these JAK inhibitors. In case of axial, you will use in this condition either TNF inhibitors or interleukin 17, not interleukin 12, 23, because not approved for axial affection. And the same, you will check after 3 months if you have significant improvement. After 6 months, if you have your target, yes, you will continue. If no, you will shift to another biologics from the same group. The same for axial affection. You will check after 3 months significant improvement, or after 6 months for the target. If yes, continue. If no, shift for another biologic from these groups. This is the EULAR recommendations for management of psoriatic arthritis. Let's have a note on special situations. It is advisable if you have severe skin affection, advisable to use one of the interleukin 17 or interleukin 12, 23, or the newly approved interleukin 23. They have a more potent effect on skin psoriasis. If you have active inflammatory bowel disease, don't use etanercept from TNF inhibitors. Avoid use interleukin 17. It's contraindicated if the patient has active inflammatory bowel disease. Use TNF, but what can we do if TNF fails? If TNF fails, if it is primary failure, shift it to another one, which is interleukin 12, 23. But if it is secondary failure, you may use another TNF, or you may use interleukin 12, 23. Let us have a conclusions now. Let us conclude. Psoriatic arthritis is a chronic systemic inflammatory arthritis with 6 domains, including peripheral arthritis, enthesitis, dactylitis, axial disease, psoriasis, and the nail disease. Psoriatic arthritis incurs a significant disease burden, including comorbidities such as cardiovascular disease, depression, and the metabolic complications. Early diagnosis and treatment result in better long-term outcome. Treatment should be aimed at reaching the target of remission or low disease activity by regular disease activity assessment and appropriate adjustment of therapy. The treatment landscape of psoriatic arthritis patients has changed considerably over past 2 decades. Traditional disease-modifying drugs have a modest benefit, but newer biological agents, including TNF, interleukin 17, and interleukin 23-12 inhibitors and interleukin 23 inhibitors, showing excellent efficacy in achieving disease control in most patients. Lastly, I invite you to visit our website of the Egyptian Society of Rheumatology and Clinical Immunology, EGYSIR.org. You will find many recorded lectures of the last conference of our society 2 months ago, and you will find educational activity. This is EGYSIR.org. Lastly, I thank all of you for attention and for attending, and if you have any questions, I am ready.
Thank you very much, Professor Mohammed Salah, for this really comprehensive presentation. I loved it. It's a great one. It includes all the information that we need to kickstart with on psoriatic arthritis, plus some tips. Let me just direct this question from the audience about sulfasalazine. I think you already mentioned it, but he was asking about the use of sulfasalazine in arthritis, in psoriatic arthritis, and if there is any head-to-head studies about it.
Yeah, sulfasalazine is one of the mentioned as one of the conventional synthetic demand used, but you know there is lack of evidence supporting the use of this conventional synthetic demand. There are small trials and with conflicting results. You know, methotrexate itself, which is one most commonly used in psoriatic arthritis, there is some trials giving weak response, some trials giving good responses, some contradiction. And sulfasalazine is the same. We have no evidence to support use of this. You know, we use it, of course, as I told, in proper situation, but its effect is modest, and we have no such evidence to support use of some one of them. Leflunomide also the same. All of them may be used, but there is some contradiction in the results of use in the psoriatic arthritis, and so we have no strong evidence to recommend any one of them.
Okay, thank you. Another question: if the patient with psoriatic arthritis with low disease activity, but we can still see synovitis with ultrasound, and we have high EGYSIR. The patient is on etanercept and methotrexate.
On
etanercept and methotrexate. Would I shift to another biologic, and which one?
You should use one of these validated measures which I just told you, because depending only on one component, ultrasound only, for example, something like this, I think to use these measures which I given to you, MEDA and DAPSA, and you decide if the patient is still having an active, highly active disease. Our target to achieve is a remission or low disease activity. If the patient has, by these measures, we should use a validated measure. If by these measures we have high disease activity, we'll shift to, according to the situation, we'll shift to another biologic. As I told you, the same sequence which I have shown is EULAR recommendations. You may shift to another biologic in this situation.
Thank you very much. And we have another question. According to your experience, which disease activity score do you prefer, DAPSA or MEDA, or in which situation do you prefer one over the other? Also, do you suggest screening all patients with only skin psoriasis for enthesitis and possibly of developing early psoriatic arthritis, or only patients with clinical enthesitis? And do you prefer specific clinical enthesitis score like Leeds score, or checking all common enthesitis?
Thank you. You asked me now 10 questions. Okay.
Let's
which is the first question is which score you prefer? Okay. This is a very debatable point. You know, there are several scores for spondyloarthritis, and for psoriatic arthritis in particular, there was much debate during the task force for recommendations of treat to target recommendations, which issued in 2017. This is one of the debate points, and the final voting on which score to use for psoriatic arthritis only got 51% agreement, because the much debate about a very complicated issue, and you have a disease with very wide variation. Okay, so these are as much as we can. They recommend this in the final recommendation. They think that the best for SPA is ASDAS, and the best for psoriatic arthritis, as they think, is MEDA and DAPSA. And they told only agreement about this statement is 51% from the task force.
The second question for the same person was, do you suggest screening all patients or only patients with skin psoriasis?
Screening for what?
For enthesitis.
for enthesitis. Actually, I remember a paper done in our department with Dr. Samah Abdurrahman, if she is there, for role of ultrasound detection of subclinical enthesitis in patients with psoriasis, not diagnosed as psoriatic arthritis. And we find a significant number having subclinical enthesitis, actually. And many of these will develop later on, I think, psoriatic arthritis. So this is a very way for early detection, maybe, for very early detection of psoriatic arthritis. The other thing is we have now in Ain Shams University a combined rheumatology and the dermatology clinic for psoriatic arthritis patients. Now we have a questionnaire for each patient with psoriasis. If you have a swollen joint, if you have something like that, to have an attention of the patient who is developing early psoriatic arthritis. The important is to diagnose early, not when we see this picture with pencil and cap appearance. This is not the aim.
Maybe with the ultrasound as well, because the question was mentioning which clinical score, like Leeds score or any other scoring to check for enthesitis.
It will be the same. There is much debate about also the same. And I think ultrasound is a very helpful assessment of enthesopathies. But you can use, of course, anyone you are accustomed with, you can use it. And the ultrasound of great help in detection of even subclinical enthesitis.
Great. We have a welcome from Dr. Basil Masri, the president of the EULAR. And the final question about the preoperative precautions as regarding biological agents.
According to the half-life of the biologic, it is it's not advisable to do an operation under cover of biologics because you will increase the risk of infection, as you know. According to the half-life of the biologic, you will discontinue according to the half-life of the biologic.
So, for example, if the biologics is used monthly, you prefer to
yes, to be told, yes. This is according to the half-life of the biologic, you will discontinue. Usually use 5 times the half-life of the biologic. Usually, half-life, not the half-life.
In the chat box, there was a question about Cosentyx use in the psoriasis, but I think you answered already, Professor. Do you want to give any?
If you have a severe skin psoriasis, advisable to use either interleukin 17 inhibitor, interleukin 12-23 inhibitor, or recently approved interleukin 23 P19 inhibitor.
Thank you very much, Professor Mohammed Salah, the president of the Egyptian Society of Clinical Immunology and Rheumatology, and professor of Rheumatology and Immunology, and the previous president of the department in Ain Shams University in Cairo, a senior professor in Rheumatology and an international figure, for this really comprehensive presentation and the great tricks with answering the questions. Bear in mind, for all attendees, we can still accept more questions. I finished the ones I have. So we will start with the second presentation, and Professor Salah will be ready also to answer more questions, if any, at the end. So now we will introduce Professor Carlos Thibes from Spain, the head of Rheumatology Unit in Hospital General de Villalba in Madrid. He's a consultant in Spain, and he used to be a consultant also in the UK and Scotland. He's a EULAR faculty for the ultrasound, and he has a lot of publications regarding ultrasound, and my own mentor and teacher. He will speak about the ultrasound in psoriatic arthritis. So the platform is yours, Carlos, please.
Thank you very much. Thank you very much, Adham, for this nice presentation. And thank you very much to the organizers for inviting me to participate in this scientific meeting. It's an honor and a pleasure for me to be with you and to share this board with Professor Salah. By the way, congratulations for very clear and very good presentation. What I'm going to present to you tonight is about the value of ultrasound in the diagnosis and management of psoriatic arthritis. And I want to present this topic with a mix between a scientific review of the evidence and some pairs of my clinical experience, especially regarding how ultrasound can be very helpful for the management of our psoriatic arthritis patient in our daily clinic. I can go further with the presentation. I don't know why. I have a problem with the presentation. To advance. Let's see. I'm going to share again because I can advance the presentation. Okay, that's fine. Then this first slide, I want to show you in this first slide all the features of spondyloarthritis, and to keep your attention about which of them can be perfectly assessed by ultrasound. I have announced in green these clinical features that definitely for the review of the literature we can use ultrasound because has demonstrated validity and sensitivity to assess this, like peripheral joint involvement, dactylitis, and enthesopathy. Ultrasound can be helpful as well to assess skin and to assess nail involvement. I have enhanced in green as well. And there is some discussion about the utility of ultrasound for the assessment of sacroiliitis. We will review later all the papers regarding this utility with this topic. And definitely ultrasound is not have been helpful in the assessment of axial involvement due to very deep location of the lesions in these cases. We have from 2015 recommendations of from the EULAR regarding the use of image and including ultrasound in the assessment of spondyloarthritis, included psoriatic arthritis. Ultrasound can be helpful for diagnosis. We can assess peripheral arthritis, we can assess enthesitis, tenosynovitis, and bursitis. Ultrasound can be helpful for monitoring disease activity using power Doppler or using color Doppler that is going to offer us information about the local inflammation, the active inflammation, and this can be very helpful in terms of decision making with treatment. And finally, despite EULAR state that X-ray continue being the image technique recommended for monitoring structural changes, we know that the sensitivity of X-ray is very low for early diagnosis of these structural changes, and in this case, MRI and ultrasound can provide additional information. As Dr. Salah has explained in his nice presentation, psoriatic arthritis has different domains, and in this presentation we are going to move step by step for these different domains in psoriatic arthritis, and we are going to analyze if ultrasound can be helpful for the assessment of these domains. What is the interest in ultrasound in these domains? Has interest in terms of the ability to identify early lesions, and we can do early diagnosis. Has interest in terms of monitoring, in terms of grading, and in terms of characterized lesions, and this is important for monitoring and for decision making with the treatment. And finally, with the help of ultrasound, we can deliver local treatment in difficult joints and difficult anatomic regions in our patients with psoriatic arthritis. As Dr. Salah has explained, arthritis of psoriatic arthritis has very variable clinical pattern, affecting hands from symmetrical polyarthritis or asymmetrical poly or oligoarthritis. That is a presentation quite similar to rheumatoid arthritis, and in this case, ultrasound can be very helpful for make the differential diagnosis. As well, can be psoriatic arthritis can have a pattern of affecting DIP joints or affecting joints with a form of destructive mutilans arthritis. In this case, especially when there is affected DIP joints, we need to do the differential diagnosis with erosive osteoarthritis. And at least in my clinical practice, this differential diagnosis used to be very complicated, and I find that ultrasound is very helpful in the management of my patients. As well, peripheral psoriatic arthritis can offer a pattern of oligoarthritis affecting large joints. Again, as Dr. Salam has explained perfectly, sometimes X-ray can offer information very suggestive of the diagnosis of psoriatic arthritis. For example, the presence of bone resorption or telescopage that is very suggestive of mutilans destructive arthritis, or when there is marginal erosions with new bone formation, which is typical again of psoriatic arthritis. But sometimes the findings can be indistinguishable of osteoarthritis, and in this case we can trust in a ultrasound for make the diagnosis. This can be the typical picture of a patient with early psoriatic arthritis, a patient with past familiar history of osteoarthritis and with pain and mild swelling in these both joints. We are going to see later how in this case, that is one of my patients, ultrasound can be of help. Ultrasound has the ability of to perform an early diagnosis in psoriatic arthritis. The papers that has been published show that ultrasound is more sensitive than the clinical exam for detect synovitis in joints, and compared with MRI and scintigraphy confirms the validity of ultrasound. And ultrasound and MRI has more sensitivity than X-ray in detecting synovitis. As you can see here in this image, there is a case of synovitis affecting PIP joint. There is a distension of the proximal recess of the joint, and there is tenosynovitis of the flexor digitorum tendons. There is distended of the sheath of the joints. the seat of the tendon that is typical of the tenosynovitis and arthritis of early psoriasis. And we can trust in the information of the power Doppler. This is a DIP joint with a palmar approach. There is the attached enthesis of the flexor digitorum longus, and there is a distension of the capsule of the joint with significant power Doppler signal, which is again typical of psoriatic arthritis with the peripheral affection. Moreover, that the identified early synovitis, we can grade this synovitis, and this again can have an importance in terms of decision of the treatment. We can check with this the severity of our patient. And for that, we use in grayscale, in V mode, the score system that was published by the OMERAC in 2017, that moved from grade 0, that is normal, to grade 3, that is the worst severity. In grade 1, there is a distension, a mild distension of the capsule of the joint. This is a metacarpophalangeal joint, but only affect to the proximal or to the distal recess. In grade 2, there is a distension from the proximal to distal recess, but the upper level of the capsule is flatter. That means that it still is possible to distend this capsule more. And the grade 3, there is a worse stage, that there is a distension from the proximal to distal recess, and there is a bulging of the upper level of the capsule, because there is not possible to distend the joint more. We can use this in the small joints, but we can apply this score to large joints like the knee. This is the proximal recess of the knee joint. Moreover, that in gray scale, we can use ultrasound for grading Doppler signal. In this case, the severity goes from grade 1 to grade 3. Grade 1 is when there is less than 3 isolated signals of Doppler that appear like these spots. Grade 2, there is when there is confluent vessels, more than 3 isolated signals, and affect less than 50% of the joint. And grade 3 is when affect more than the 50% of the synovial area. And again, we can use for small joints, or we can use for large joints like the knee. Moreover, that to detect synovitis with ultrasound, we can do early detection of erosions. And erosions in peripheral psoriatic arthritis is the hallmark of joint damage. And we know, according to the studies that has been published, that early detection of erosions and great number and big size of erosion are related to poor outcome. For this reason, we try to detect erosions in our patients, because this has implications in choose the more proper treatment for the patients. The papers that has been published say that MRI and ultrasound has higher effectivity than X-ray to detect these erosions. And even some papers say that ultrasound can detect more erosions than MRI. In this image, you can see an MTP joint. This is the metatarsal head. This is the base of the phalange, and there is an erosion here in longitudinal view, and in transversal view there is a cortical defect. We define erosion like a cortical defect that we see in two projections, longitudinal and transversal, and in addition we have a power Doppler signal within the erosion. That means that this erosion is active, and if we don't start a treatment, probably this erosion is going to progress and to become bigger and worse. Another important role of ultrasound is to support the assessment of difficult joints. This is the case, for example, of the ankle joint. This is the situation that we have in our clinics frequently. This is a very swollen ankle that for the physical exam we cannot differentiate if this is for synovitis, tenosynovitis, or perhaps a soft tissues implication. Then in this case, ultrasound can be very helpful for differentiate if there are synovitis here and even for apply local treatment. This is the image of ultrasound of the ankle. This is the distal tibia. This is the subtalar. This is the talar bone, and this is the joint space, and this is the extensor, tibialis extensor. In this case, we can see how there is a significant synovitis. There is distension of the capsule of the tibiotalar joint for this hypoechoic content. Then, in this case, with ultrasound, we can differentiate the different features that produce this swelling. The hip joint is another joint difficult for the clinical exam, and ultrasound can be very helpful to know what's going on when we have a patient with pain in the groin area. The ultrasound offers an image that is quite similar as using in this image to the real anatomy of the joint. And following with a case where ultrasound can be helpful in the management of difficult joints, I'm going to start for the presentation of one of my cases from my clinic. This is a lady, 49-year-old, that was diagnosed of psoriatic spondyloarthritis B27 positive in 2010 because inflammatory back pain that was in good control with non-steroidals. But she came to my clinic in 2016 complaining of local pain and swelling affecting elbow, ankle, and especially right knee. She started prednisolone 20 milligrams, and elbow and ankle improved, but still right knee was swollen, especially in the popliteal area, and she couldn't bend the knee properly. In the ultrasound scan in the popliteal area, she had a large Baker cyst in all this area that make difficult to the patient to bend the knee. We decide in this case to stick a needle inside, to aspirate, and to deliver corticosteroid inside the Baker cyst. And as you can see, the ultrasound can be helpful to ensure the proper placement of the treatment inside the Baker cyst. The patient was stable from 2017, 2018, but in 2019, she came again to my clinic because a flare of pain in the right groin area with limited function of the right lower limb. I was suspecting something about the hip joint, and we decided to do an ultrasound scan, and we can see this significant synovitis grade 3. This is the femoral head, the femoral neck, and there was distension of the capsule of the joint from the proximal to the distal recess that you can see in this image in longitudinal and in transversal. we decide again to stick a needle inside this synovitis. This was effusion. We differentiate effusion from a synovial hypertrophy because when there is effusion, we can compress with the transducer, and the synovitis is compressible and displaceable. But when there is synovial hypertrophy, there is partially compressed, but there is not displaceable. Then we stick a needle inside, ensuring the proper placement of the tip of the needle, and after that we aspirate synovial fluid that you can see in the image of the left-hand side. And again, we ensure a proper placement of the treatment, the corticosteroid, inside the knee, the hip joint. I ask the patient to come back again to my clinic for control the evolution, and after 2 weeks, this synovitis, this effusion completely was disappeared, and you can see here that the capsule of the joint is close to the bone profile. That means that there is not any synovitis at all. Then ultrasound in this case with my patient was useful for decision making with the therapy, in this case local treatment, to guide this local treatment and to monitoring the treatment response. We move to another domain, that is enthesitis, and enthesitis is very important because most of the authors are agreed that is the hallmark of psoriatic arthritis. As Dr. Salah has explained, can appear between 50 and 90% of psoriatic arthritis patients, depending if we consider clinically or with image. Is important because to identify enthesitis can be helpful for differential diagnosis with other forms of arthritis, such as rheumatoid arthritis. There is a few papers that say that in patients with psoriasis, to detect subclinical enthesitis in ultrasound predicts future development to psoriatic arthritis. And it's important because it's a clear indicator of disease severity, indicator of more disease activity, more peripheral joint and axial damage, and more patient disability. Then, in the top of that, in the pathological studies, enthesitis seems to be the primary process underlying psoriatic arthritis, and for all these reasons, an early detection that we can do with ultrasound is clinically important. You can see here, this is the Achilles enthesis, that is the most common presentation of enthesitis in patients with psoriatic arthritis. And in 2014, the OMERA group published the main ultrasound lesions in psoriatic, the main ultrasound lesions of enthesitis in spondyloarthritis. These main lesions affect the tendon. This is again the Achilles tendon enthesis, and produce thickening of the Achilles tendon, the enthesis of this tendon, and produce some hypoechogenicity with loss of the typical fibrillar pattern of the tendon. Another lesions are enthesophytes that appear like this hyperechoic line that continues with the calcaneus bone, or calcification that appear like hyperechoic image, lineal image with acoustic shadow, or erosions in the enthesis that has to be identified in longitudinal and in transversal, and a power Doppler signal that has to be, according this description, located less than 2 millimeters from the tendon attachment. These lesions are not specific of the enthesitis of spondyloarthritis or psoriatic arthritis can appear in other, are very typical, but can appear in other diseases, like, for example, erosions in gout or even power Doppler signal that probably Dr. Adham in his lecture in the next edition is going to describe, and we are going to familiarize with that. On the top of this lesion described by Omerab, there is another lesion that are very common and we used to see in our patients when we scan. One of these is a power Doppler signal more distally, more proximally to the attachment of the tendon that appear especially in the lower levels, in the lower part of the tendon, and seems to be arise from the anatomic area of the retrocalcaneal bursa, or retrocalcaneal bursitis, or bursitis and other entheses like infrapatellar entheses, for example. This is quite common. In another advantage of ultrasound is that for enthesitis is that can differentiate findings of activity from findings of anatomic damage, and this is important in terms of decision making with the treatment, especially when there is power Doppler signal in the entheses or in the bursa. This means that this process is active. Probably we need to be more aggressive with the treatment. That when we see this anatomic damage and there is not power Doppler signal, perhaps this can be chronic findings, and we have to trust the rest of information of the patient for decide the treatment. As I have explained, the utility of ultrasound for the deliver local treatment in difficult joints for the physical exam, ultrasound can be helpful to guide treatment to inflamed entheses, to swollen entheses. This is the case of one of my patients with psoriatic arthritis that was complaining of pain, swelling, and limited function located in the area around the bursa. And you can see here how we place the needle inside the bursa and how we can inject and we can deliver treatment and ensure that this treatment is placed inside the bursa and not around the bursa. There has been published several indices for assessment of enthesitis at the patient level. This indices was published related to spondyloarthritis, and more recently has been published indices more related specifically to psoriatic arthritis. The first was published in 2002 for the group of Glasgow, over 5 entheses of lower limbs with describing 18 features, and then with a score from 0 to 18. Our group of Madrid in 2007, over the same entheses of lower limbs and using a grayscale only B mode, published a new score with more findings, and we differentiate findings, acute findings from chronic findings that we thought at that time that can have therapeutic implication in the patient. And more recently, in 2009, in this multi-center study of Madrid, the MASEI, scoring, in this case, entheses of the upper and lower limbs and using a power Doppler, was done like a comprehensive score of the wall entheses with a score from 0 to 136 features. This score show high sensitivity and specificity for a score at the level patient regarding the enthesis. This same score Massey, the group of De Miguel has been applied to patients with specifically with psoriatic arthritis, and they have demonstrated a good reliability of this Massey score in patients with psoriatic arthritis, and they conclude that Massey can be used in psoriatic arthritis as well. And this is an interesting study, the interesting work, because there is a composite. This author described a composite score of not only the assessment of the peripheral joints in psoriatic arthritis, but even the assessment of enthesitis. The start point is a comprehensive assessment of joints and enthesis with a total of 68 peripheral joints and 14 enthesis. From this comprehensive score, they move to more reduced number of joints and enthesis score, and find that with this 22 peripheral joints and 4 enthesis, and with this with 13 peripheral joints and 2 enthesis, this score has enough validity, sensitivity to change, reliability, and of course feasibility for apply in patients with psoriatic arthritis. And this is important because a comprehensive score probably you need approximately 1 hour to perform, but this reduced with 5-10 minutes is enough for a proper scoring system. We move now to another case that show how ultrasound can be helpful for early diagnosis when we can identify subclinical enthesitis. This is a 42-year-old patient with past familial history of osteoarthritis that came to my clinic with pain located in the third right PIP joint and second left DIP joint. There was not so much in terms of swelling in the physical examination, perhaps this finger a bit dactylitic, and perhaps a bit of swelling distally. The patient has been on non-steroidal with a poor response, and the GP sent to rheumatologist. When we scanned the third finger, we could see a tenosynovitis of the flexor digitorum tendons. There is distension of the capsule of the joint, the capsule of the the sheath of the tendon, and there was a synovitis of the PIP joint with this distension of the proximal recess of the joint, and we can ensure this tenosynovitis on transversal approach, comparing with other tendons. When we scan with power Doppler, we could see how this tenosynovitis was active because there was a power Doppler signal, especially located in the sheath of the tendon and in transversal. This was located, especially like a ring around the tendon, that is the area of distended of the sheath of the tendon. We scan the DIP joint area, and in palmar approach, we can identify distension of the proximal recess of the joint for this content with power Doppler signal. And in the dorsal approach, we can recognize this is the base of the distal phalange. This is the distal intermedial phalange. This is the extensor tendon attaching in the base of the phalange. We could see how the enthesis was affected. There was distended the enthesis, the end of the tendon, and was hypoechoic, and there was a power Doppler signal around, which is typical of enthesitis of psoriatic arthritis. This is the another finger asymptomatic. This is the extensor tendon attaching here, and there is not any enthesitis here. Then in this case, ultrasound again was very helpful for to set an early diagnosis and to do the differential diagnosis, in this case with osteoarthritis. We move now to dactylitis, and dactylitis, in general, we don't need any image technique for diagnosis of dactylitis because dactylitis is a clinical diagnosis. Can affect up to 50% of psoriatic arthritis patients, used to be asymmetrical, more affecting right side and feet, is a part of classification criteria of CASPAR, and for this reason, if there is not possible the clinical diagnosis and we suspect dactylitis, we can use ultrasound with more accuracy than the clinical examination for diagnosis, and is a component of composite clinical scores of psoriatic arthritis. Again, as we explained with enthesitis, is a marker of disease activity, is marker of worse X-ray progression and predictor of cardiovascular risk. Then to identify dactylitis is important. Despite there is not completely agreement about the findings in dactylitis, more of the authors think that at least there is 3 common findings, that is tenosynovitis of the flexor tendons, synovitis of the MCP, MTP or IP joints, and thickening of soft tissues like cellulitis. There is another findings, according to other authors, some of them, like the bone marrow edema, has to be seen for MRI because ultrasound has not the ability to recognize these findings. And again, in this case, is that it's difficult to diagnose dactylitis. For the clinical exam, we can use ultrasound because we can detect tenosynovitis. This is flexor tenosynovitis of the second toe with distension of the sheath of the tendon. This is the MTP joint. We can diagnose peripheral arthritis of in this case of the MTP joint, or we can observe this thickening of soft tissues, this change of the normal cohenicity of the subcutaneous tissue, that is typical, the typical peritendinous or perienthesis swelling. And these findings have shown good validity compared with MRI in the diagnosis in the different components of dactylitis. I bring this study, very interesting, is from the group of McGonagall that has been working in pathophysiology of the different domains of psoriatic arthritis. This has been published last year, and in this paper they discuss about the pathophysiology of dactylitis. And they introduced the interesting concept of functional enthesitis to explain the different findings that we can observe in dactylitis. For the finding of tenosynovitis and extratendinous inflammation, they think that the accessory pulleys from A1 to A5 works like a functional enthesis, and through the comprehensive and tensile stress to the tendon, they produce the the swelling that finally we can observe like tenosynovitis or thickening and inflammation of the soft tissues around. The enthesis of the collateral ligament, working again like a functional enthesis, works the cause of synovitis in the peripheral joints of dactylitis, and finally the compressive stress of the extensor tendons over the surface of the bone of the phalange works like a functional enthesis again, and is the cause of tendonitis and peritendonitis. Some studies with MRI with enhanced contrast media has observed that in early stage of dactylitis, the inflammatory process starts by these ulays that will be the starting lesion for dactylitis, supporting this pathophysiologic theory of the group of McGonagall. Sacroiliitis. There is the one of the first papers that was published in 2005 trying to test the validity of color Doppler ultrasound for the detection of sacroiliitis. They use MRI like gold standard, and without use contrast media, they observe low sensitivity with good specificity and good predictive values. With the use of contrast media for ultrasound, they increase the sensitivity significantly. The issue here is that the use of contrast media for ultrasound is more expensive, and even can have potential adverse effect, and for this reason we don't use on routine basis. And this table summarizes the whole most of the most important papers that has been published assessing the validity of color Doppler for the diagnosis of sacroiliitis. As you can see, most of them use MRI scan like gold standard, except this physical examination. All the studies with a large number of patients and with controls, and they find high sensitivity between 60 and 90% and high specificity for the detection of sacroiliitis. Even using the resistive index, that is instead of semi-quantitative method is quantitative, they increase this sensitivity and specificity. However, most of the authors discuss that there is limitation for the use of ultrasound for the assessment of sacroiliac joints, especially related to there is not a standardization of the method or the settings of the machine, and there is problems related to the proper anatomy of the sacroiliac joint, because its deep location, because the proper shape of this joint. And for this reason, we cannot assess the medial and inferior joint, and early lesions that affect the sacroiliac joints are related to the subchondral bone and has to be assessed for MRI. Then still limitations for the regular use this procedure. Regarding indications for the use of ultrasound in sacroiliitis, one of that is when we want to guide local treatment, or when there is not availability or there is delay for use MRI scan. There is or when there is contraindication for MRI, but you need to know that there is not recommended for EULAR for the assessment of sacroiliac joints. How we scan the sacroiliac joints? We scan sacroiliac joints, look for this spine of the sacral bone in transversal. We place the transducer on transversal. We identified this spine of sacral bone, and this is the sacral wing. And we move the transducer laterally until we see this convexity, this concavity, that is the joint space of the sacroiliac joint. Of course, this is difficult when the patient is an obese patient, because we scan in this. That is one of my patients. This is an slim lady, about this is depth approximately 1.52 centimeters, but in obese patients perhaps this is 3-4 centimeters, and the resolution of the image is not so easy. Even we can scan with power Doppler, and in this case, when there is active swelling, we can identify the power Doppler signal within this sacroiliac joint. Regarding skin, I have only this slide because perhaps nowadays still rheumatology, we are not very interested in the assessment of skin with ultrasound. But I only want to show you the difference between a healthy skin and between a psoriatic plaque. In normal conditions, epidermis is this thin superficial band that appear here between these two arrows. This is dermis, and this is hypodermis as subcutaneous tissue. When there is a psoriatic plaque, we are going to see a thickening of this epidermis and thickening of the dermis. And we are going to identify these hypoechoic bands, especially in the superficial areas of the skin. And of course, because there is an swollen skin, there is more power Doppler signal compared with the normal skin. However, with nail, I think can be more interesting for us as rheumatologists for assess our patients for early diagnosis. I'm going to explain with more detail in the next slides. This is a very nice paper published in 2009 for rheumatologists and dermatologists, because describe very nice the findings of a normal nail and comparing with psoriatic onychopathy. We need to know about the ultrasound of the nail, that there is, of course, the bone reference that are very helpful for identifying the different structures. That is this, the distal part of the medial phalange, and this is the distal phalange, all this hyperechoic line. Arising for this line, there is this these two hyperechoic lines with one hypoechoic line inside. That is the plates. This is the dorsal plate, and this is the ventral plate. And we need to identify this space that used to be hypoechoic and homogeneous, that is the nail bed. And this other space more proximally, that is the nail matrix. And as you can see here, the extensor tendon is attaching here. What happened in psoriatic plaque? In psoriatic plaque, we are going to lose the definition of the attachment of the extensor tendon. We are lose the definition of these three lines, and appear a hyperechoic band with a wavy aspect of the surface, and thickening of the nail bed and thickening of the nail matrix. That are the typical findings of psoriatic onychopathy. In normal conditions, nail has vascularity. Then we can identify this power Doppler signal that is very homogeneous, like spots in comparison with when there is onychopathy, that is, there is local swelling, there is more inflammation, and there is a power Doppler signal that is large signals, less homogeneous, and affecting the whole nail bed, affecting the nail matrix of all this area. And in the last annual meeting of GRAPPA, they published a nail score, a nail enthesis score. For this score, they consider anatomy, morphometry of the findings, and power Doppler signal. Then they assign 1 point when there is a thickened the nail matrix or the nail bed, and when there is changes in the nail plates. And power Doppler, they assign from 0 to 3, depending on the severity of the power Doppler signal. With this can be helpful to check, to monitoring the evolution of our patients or the response to the treatment. There is some theories of pathophysiology of lesion in psoriatic arthritis, and according to these authors, the inflammation in the complex enthesis, joint and nail started for the enthesis and moved distally to the nail and proximally to the joint. And depending on which part of the nail is more affected, appear these macroscopic lesions. I am personally interested in the complex enthesis, joint and nail, because I think the carefully observation with ultrasound of these different components can be very helpful in terms of to do an early diagnosis of psoriatic arthritis, and in terms to do a differential diagnosis, especially with osteoarthritis that commonly is quite difficult. In the left-hand side, you have the typical findings with ultrasound. You can see this in gray scale, thickening of the enthesis, hypoechogenicity, and with power Doppler around this enthesis, there is a significant power Doppler signals. That means that there is active inflammation around. More proximally, we can see in our patients with psoriatic arthritis affecting the IP joint, distension of the proximal recess of the joint with power Doppler signal. And what's happening in osteoarthritis? In osteoarthritis, for example, if it's mild osteoarthritis, what we are going to recognize that is the enthesis has not thickened, there is not any finding of enthesitis. We can recognize mild synovitis in the proximal recess of the DIP joint, and with power Doppler, there is not any power Doppler signal around the joint or inside, around the enthesis or inside the joint. Mind that those sometimes erosive osteoarthritis can have a power Doppler signal in the joint, especially if we have an ultrasound with enough sensitivity for detect signal. And what happens in severe osteoarthritis? In severe osteoarthritis, we are going to see significant change, osteophytes, or this ring of osteophyte in the metacarpal, in the intermedial phalange. We can see distension of the proximal recess, mild synovitis, but we can see how the tendon is completely normal and there is not any enthesitis similar to the psoriatic. And even with power Doppler, we don't see any synovitis in this area. Then I find very interesting to use ultrasound in this patient that we have some difficulties for differential diagnosis because the implication on therapy. And for conclusion, a few home message that to summarize all the information of this presentation. Musculoskeletal ultrasound is a useful tool for early diagnosis, grading and monitoring of peripheral arthritis and enthesitis in psoriatic arthritis. This is accepted for more of our colleagues that use ultrasound in the assessment of their patients. Ultrasound can accurately identify the findings in subclinical dactylitis. Is still under discussion the real usefulness of ultrasound in the assessment of sacroiliitis, but may be indicated with MRI is not available. Ultrasound offers an added value for the assessment of difficult joints and for guide local treatments in psoriatic arthritis. And I find, and I am very interested in this idea that there is a potential of ultrasound exam of the enthesis nail joint complex of the fingers for early subclinical and differential diagnosis of psoriatic arthritis or osteoarthritis, which needs to be investigated further. And now that we are finishing this 22, that has been very hard, we are with expectation for the new year. And because we are close to finish this year, I want to wish you a happy 2021, hopefully much better than this 2020. Thank you for your attention.
Thank you very much, Dr. Carlos Acebes, for this great presentation, comprehensive, detailed, and elegant. And actually, we have some questions for you and also for Professor Salah. Let's start with this question to you, Dr. Carlos. How to differentiate mechanical and inflammatory enthesitis? Some of mechanical cause can cause calcification, Doppler, and spare.
Okay. I think in the last slide, I tried to explain the difference. Okay. In terms of calcifications or enthesophytes, both can produce a mechanical condition, can produce enthesophytes, can produce calcifications, and there is not a specific of psoriatic arthritis or not a specific of a mechanic condition. Then we need to trust of the clinical symptoms of the patient. Regarding power Doppler signal, as I have explained, in erosive osteoarthritis that sometimes present some kind of inflammatory flares, and especially if you have a very sensitive machine, you can pick some power Doppler signal, but in general, it's going to be more less expressive than the signal that you can see, for example, in psoriatic arthritis or inflammatory conditions. But I trust more in the enthesis, in the enthesitis, in findings suggesting enthesitis to differentiate both.
Another question by ultrasound, how to do a differential diagnosis of paronychia and distal enthesitis and psoriatic nail. I think you also covered this, but if you want to give a hint.
Yes, again, I think I have answered in the last slide. Paronychia is affecting more to soft tissues, has not to be any kind of typical enthesitis, and I think paying attention to this complex enthesis, nail, and joint, we can differentiate.
A question by ultrasound, can I differentiate synovitis and erosion in polyarticular subtype of psoriatic arthritis with rheumatoid factor positive from rheumatoid arthritis?
Okay. When I this situation, I used to ask the patient for symptoms of enthesitis. And if the patient don't say any active symptoms of enthesitis, I used to go with ultrasound to check and to try to pick subclinical enthesitis. And I used to go to lower limbs. I used to go to the Achilles enthesitis, to the knee, and then sometimes this can offer me the differential diagnosis of these cases. And for example, thinking, for example, in tenosynovitis. Tenosynovitis can appear in inflammatory arthritis, rheumatoid arthritis, or can appear as well in psoriatic arthritis. The difference between both is that in psoriatic arthritis, the soft tissues around the tenosynovitis used to be more thick, used to be especially can have a power Doppler signal. Then I trust as well about these findings, but sometimes it's difficult to differentiate.
Professor Salah, this question is for you. Is biological therapy should be lifelong with psoriatic arthritis? And what about rebound skin psoriasis after cessation periods in between the injections?
You know, in all rheumatic diseases, we use biologics. We reach our target of remission or disease activity and keep this target to be sustained during the course of the disease. When we reach a state of steady or deep remission, or at least low disease activity, for a long time, not less than 6 months, not less than 6 months, or 1 year better, we can taper the biologic, but not to discontinue. We can taper gradually, either by widening the space or by reducing the dose if possible. And we will follow by our measures. If we have a flare, we should return back to the last dose. If we haven't, we can continue tapering till discontinuation. In some cases, whenever you start early, you can reach the drug-free or biologic-free remission at one time.
Thank you. This is another question to you, Professor Salah. What to give to a patient with cardiac disease and psoriatic arthritis? Also, what to give to psoriatic arthritis with inflammatory bowel disease?
Inflammatory bowel disease, already I have mentioned already, if you have patient with psoriatic arthritis or ankylosing spondylitis and inflammatory bowel disease, you can give any one of the monoclonal TNF inhibitors, not etanercept. If there is contraindication for TNF inhibitors, or if no response, primary failure, for example, for TNF inhibitor, you can try another biologic, interleukin 12-23 Secukinomab, is available in Egypt now, EULAR. It is indicated for treatment of Crohn's disease, also have an indication, have an approval also for treatment of Crohn's disease. But as I mentioned, for heart failure, if you have severe heart failure, you don't mention which form of heart disease, ischemic heart, or in case of heart failure, if we have grade 3 or 4, New York classification of grade 3 or 4 heart failure, this is contraindication for TNF inhibitors. In this situation, we can use interleukin 17 inhibitor, interleukin 12-23 inhibitor, interleukin 23 inhibitor. We have now different choices other than TNF.
Okay. I think this last question is common between the two professors tonight. Would you change biologic therapy based on ultrasound activity only? Professor Salah, what do you think?
For me, I used to have a judgment by validated measures. I have validated measures according to the recommendations. It's full recommendations. We use validated measures, and ultrasound will be of help for assessment with me, but not the only decision. I cannot decide only on ultrasound based. I have a validated measure, including multiple scores, multiple points to judge. So we have the chance to have several points, not 1 point judgment.
I would like to I would like to comment that we are rheumatologists, we are clinicians, we are not radiologists. Then we have the great advantage that we have the patient, we can ask the patient about symptoms, we can examine the patient, and most of the times ultrasound is a confirmation of our clinical suspicion. That I never base only my decision of a treatment only in the findings of ultrasound. Of course, I love ultrasound and I think offer a significant value for decision making with the patient, but you need to have like a comprehensive information of the patient, and in this case ultrasound can be helpful, but I don't base only on ultrasound, despite I love ultrasound.
Okay, thank you. Dr. Basil Masri, President of the EULAR, is directing the question to Professor Salah. Professor Salah, do you have any policy for the use of COVID-19 vaccine for patients on biological DMARDs and conventional DMARDs?
Alan, Dr. Basil, Alan, this is the most debatable question now, Dr. Basil. Why you are giving me this question now? You want to put me in a political situation now? We have no enough data about any vaccines available now for COVID-19. We have no safety data, no long-term follow-up. We have no, we have no full idea about now. But we can follow the vaccination policy recommended by different authorities before, if live vaccine or non-live vaccine, the same. But about the outcome and for how long it will give immunity, and what about the side effects on long term, this needs, of course, follow up for a long time. All Chinese one is okay, Russia one is okay, and the American one is okay, and Oxford one is okay.
Thank you very much, Professor Salah. Thank you very much, Professor Enthesitis, for those very helpful, detailed, elegant, and comprehensive illustrations today. I was really enjoying it. Just to remind everyone, I will share the screen on. This is just a reminder. I hope you can see it now as full screen. Today we had the pearls in the diagnosis and management of psoriatic arthritis, and on the 14th of January we will be honored to have Professor Ghaffar Ragab to speak about the gout. On the 28th of January we will be honored to have Dr. Basil Masri and Professor Nemanja Dimaniov to speak about the osteoarthritis versus early rheumatoid arthritis. You will have to register for the events. Probably I will provide the links as usual, and follow up the groups online to do this. At the end, I would like to thank Amgen again and Iris for holding the platform. Our speakers tonight, Professor Salah, the head of the Egyptian Society of Clinical Immunology and Rheumatology, and the ex-president of the Rheumatology Department in Ain Shams University, and Professor Carlos Enthesitis, the head of Rheumatology Department in General Hospital de Villalba, and one of the EULAR faculty of ultrasound. Thank you very much for bearing with me tonight, and I thank you all the attendants tonight for keeping around 2 hours with us now, and I wish you a happy New Year and a nice evening tonight. Thank you very much.
Okay.